Well, good morning, everyone. We are so excited to have Dr. Brian Eichner join us. He's a diagnostic pediatrician with Duke Health Systems, and near and dear to Eden and mine's heart because he is our pediatrician and love him to death as a pediatrician. But he is going to talk about diagnostics pediatrics and some of the stuff that's going on with Duke and share a slideshow with you. And Dr. Eichner, welcome to the Rare Fair, and thank you so much for taking the time.
All right. Well, thank you guys for having me here. This is a pretty neat opportunity for me to kind of talk to a mixture of, families and other health professionals, which always makes your brain have to work differently to figure out what you're going to say. So for me, this is kind of neat. But anyway, the title of my talk is Navigating Diagnostic Pediatrics for the 3 Ps, Patients, Parents, and Pediatricians, because this is a bit of a whirlwind for I think everybody on all sides. So there we go. So I don't have any relevant financial disclosures. I think an important disclosure for me to make is I don't have any extra special training. So I'm not a geneticist. I'm a general pediatrician. So I spend a good portion of my time primary care, ear infections, asthma, COVID, ADHD, well babies, vaccines, etc. But I also take care of a lot of kids with special healthcare needs and also do a diagnostic clinic. So I come at this from the angle of a primary care pediatrician who just believes that all kids really deserve a good, complete pediatrician. And I also come at it from a parent. Luckily, I have healthy children, but I think it's helped me gain some perspective on what you all go through, because even simple things seem stressful. So I'm here because the Lord family was kind enough to invite me. But really, as we think about treating and we get better at treating and preventing common illnesses. So 30 years ago, my colleagues were doing lumbar punctures constantly for things like Hib meningitis, epiglottitis, pneumococcal meningitis. And with those vaccines, that stuff kind of got better right before I started my training. And the role of general pediatricians is really evolving. And it's really evolving to, I think, really figure out how to tackle 2 niches. So one is figuring out the things that affect children's health outside of our walls. And these are what we call the social determinants of health. So things like social injustice, racial injustice, gun violence, family stresses, food insecurity, education, things that really impact the large part of young people's health. But I think the other area we need to get better at is how to figure out rare diseases, kids with special healthcare needs, because we now have kind of, I think, the bandwidth to really do a better job taking care of those kids and knowing how to evaluate them. So we really need to work on getting better at this. So my goal today is to really talk about how it is that I think families and pediatricians can better communicate, figure out what we each have as our own blind spots towards doing better. And I really want to say that we need help doing a better job, and we count on our families to really help us through this process, oddly enough. And this is definitely true of myself. I think sometimes when I give a talk like this, it can come off as all-knowing and that I know this and you all know nothing. It's just really not true. I really want to help you guys kind of learn from where I've had to think this through for myself. So I'm definitely no smarter than anybody else on this call. And I hope that it doesn't come off that way. So this is my disclaimer that it can sound a little preachy. So our objectives are really look at the impact that the diagnostic process and that time before diagnosis can have on patients and families, which some of you know quite well. Look at the barriers to achieving diagnosis and the appropriate access to care. Utilize the knowledge of these barriers to improve how we diagnose kids. Explore the role that race and lack of equity play in diagnostic peds. And study the impact that the COVID-19 pandemic has had on rare disease diagnosis, and figure out what we can learn from this towards future evaluation. So a lot of this could probably be similar to stuff with adults. I only take care of kids, so I'm going to focus on those. So why is it important to achieve the diagnosis? Well, common sense would tell you to treat disease. And this is true, because for many diseases, the treatment's diagnosis specific. So for some metabolic disorders, some of which are found on newborn screen, targeted treatments or avoiding certain nutrients are really important. For leukodystrophy, a bone marrow transplant. For certain types of seizure disorders, depending on what the actual underlying diagnosis is, impacts which anti-seizure med is going to be the best choice. And then definitely, it's easier to move on when you know what's wrong, or rate might be different about you or your child. Keeping in mind it's okay to start some therapies before knowing. So, developmental therapies, speech, occupational, physical therapies, a lot of those types of things. It's okay to start those before you truly know what's going on. Understanding recurrence risk for families. So even though families love each of their children and want to always be with them, it's helpful for families to know, do they have the bandwidth to have and the ability, financial, other resources, if they were to have another child with the same condition, could they handle it? What's the risk of it? Planning for future independence. How do we look at our kids 15 years from now when they're growing up? And then, just a sense of belonging. How it's easier to find connections within a specific rare disease community. I think you guys can tell me otherwise. If you actually have people that you can connect with based on an exact diagnosis. But despite knowing all this, it takes a long time to diagnose kids with rare diseases. This isn't kid-specific data, but in a survey from National Organization of Rare Disorders, 36% of people got diagnosed in the first year, which stunned me that it was that high. 28% for 7 or more years, and 38% received a misdiagnosis. And that surprised me with how low it is. The numbers are actually worse than they were in 1989, which makes me wonder how much of this is due to there being some more subtle phenotypes, so maybe kids with less severe disease now being known to have rare disorders, or just the sheer number of rare disorders that we know about now. Maybe that's part of what's made these numbers worse than they used to be. So to give some examples, so spinal muscular atrophy, there's different subtypes, and it can present really very early, later in infancy or during toddlerhood. And the ages of diagnosis lag really behind when symptoms start. So kind of somewhere in the 3.5 to 3 year window for diagnosis from time of onset to time of diagnosis. And this is published by Lynn and colleagues in 2015. That's a really long time. So for the youngest subtype, going from 2.5 months to 6 months for diagnosis is a really huge deal. These kids for those infants, are very severely affected. So inflammatory bowel disease, I wouldn't really consider this a rare diagnosis, but it's a great example. We can learn a lot from it. So the median delay before diagnosis, there's different types, so Crohn's disease, ulcerative colitis, and unspecified. And there can be a pretty long delay between symptoms and diagnosis, depending on what symptoms you present with. So if a child presents with just abdominal pain as their symptoms, it's going to take at least longer than 6 months to come up with the diagnosis. Where a more extreme presentation, like blood in the stool, will be a faster diagnosis. And we'll talk a little bit more about that in a little bit. The thing to note, though, is that a delay of greater than 6 months was associated with a higher frequency of complications. So in addition to just not feeling well, it actually really matters when you get diagnosed. So what are some other problems that come up if it takes a while to diagnose? So like I said, you can miss the window to intervene. So things like bone marrow transplant for leukodystrophy, or like I talked about, some of the complications from Crohn's disease. Just a child not feeling well. Every day that we're not diagnosing them is a day extra that they might be feeling unwell that they don't have to. Distress of not having an explanation. It's a matter of feeling believed by your pediatrician or by your school or by your other family members. Harder to find a good online support group or social media forum for you. And what ends up happening is a lot of the diagnostic attempts become parent-driven. We really, unfortunately, rely on our parents to do this for us in a way that's very different than other areas of healthcare. And this has a lot of stress for families, and also creates a lot of equity issues for families that don't have the same means to do this. So why is this stressful? So just medical stress in general, working with physicians who might kind of blow the symptoms off as being a picky eater, a boy is a boy, yada, yada, yada. Lack of knowledge really makes us feel like we're not in control. And then, unfortunately, giving bad prognostication. We are terrible as doctors at really knowing prognosis, terrible at predicting when a child is going to live, for how long, when they're going to die. As bad as we are predicting this weekend's snowstorm, I think us doctors are even worse at predicting this stuff. And when we say things like this, it can really cause harm. I have a really amazing patient who just turned 13, who I took care of back when he was an infant in the ICU. And when he was 2, and I was seeing him in clinic, I decided to have discussion with the family just to make sure we were all on the same page in terms of life-sustaining measures and code status. And the mom burst into tears, and this was my first time seeing her cry in 2 years of knowing her, and she had been through some pretty miserable stuff. So I asked, I said, it's perfectly okay that you're crying. This is a big topic, but why is this topic making you cry, whereas all of the other things I have not ever seen you cry? And she said, well, when he was an infant in the ICU, the doctors told me that he was probably not going to live until 2. So you're talking with me about this because he's 2? And I felt horrible for her that this is kind of what she had been told. So we really need to be, as physicians, be careful with our words. And I would encourage you as families to just ignore our words when we say things like this. Not useful. So some of these stressors also go on to access at the start of treatment. And so keep that in mind. That it's not just the pre-diagnosis time that's stressful, that between the time you start, you get your diagnosis and start treatment, and that can be stressful as well. So let's kind of systematically go through where the barriers are to prompt accurate diagnosis. And you can put these at the doctor level, the disease level, parent-patient level. I kind of would combine as one here, and then the systems level. Again, this can sound as if I'm casting blame on either physicians or families or the system, and I'm not. But it's important to understand what our blind spots are so we can really do better getting our kids the care they need. So I think it's always important to think about things in terms of things we can change and things we cannot change. So we change those that we can't, and we understand the impact of those that cannot. Unfortunately, though, a lot of this depends on being in the right place at the right time with the right person. So the Swiss cheese model, I don't know if any of you are familiar with this. This really kind of stems from the airline industry. We use this a lot in healthcare to figure out risk and harm. So when a sentinel event happens, there's usually a whole lot of layers of safety that are built into the system, but sometimes the lines and the holes in the Swiss cheese align, and that's when you get a bad outcome. You can think about this in terms of COVID even. So your hazard is your COVID exposure. And then you've got these lines of Swiss cheese, like, are you wearing a mask? Is the person near you wearing a mask? Is their room well ventilated? Are you outside? How long are you there? If people have been vaccinated, right? And then you can end up with an outcome if all the lines of Swiss cheese line up the wrong way. I think about this for diagnostics in the right way, but it really requires getting everything to line up. So the kid has to come with the right symptom that trips off our faulty doctor minds the right way. You have to have the doctor that's been thinking about this the right way. You have to be there on the right day when maybe your doctor's not overwhelmed with other problems, or they've just read the right article the night before. Maybe you say the right buzzword that kind of stimulates the part of our brain that remembers studying this for our boards ages ago and helps us then order the right test. So a lot has to go right, oddly enough. So keeping in mind, though, that all these levels interact with each other. So the patient might have interacted negatively with the health system before or with providers before. How do we interact with our health system? Does our health system give us enough time to see patients? How do we interact with the parent? How does a parent communicate back with us? What have providers done to try to treat the disorder before, and is that impacting the way it's presenting? So it's keeping in mind there's a really big context here. So physician level factors. So how well do we understand a particular disorder? We can't know every single disorder that exists, unfortunately, or know much about it. But I think we hopefully can know about rare disorders in general and when something doesn't seem right. How well do we communicate? How well do we listen? How well do we ask questions about families, like, what is your biggest concern? How much time do we have? Are we, trying to crank out 35 patients in a day, or do we have time to kind of sit here? And this is something that I think we can probably do better with. And that's probably a systems issue. But we also count on our families to help us with time. And I'll talk about that a little bit too. Cognitive patterns and diagnostic bias. I think it's important to understand how doctors think as a patient. Because if you do, you can help us overcome our flaws. We count on you for this. What racial and social biases do we have as physicians that impact how we interact with other people? And stress. How much does stress impact our medical decision making? If we were up all night on call the night before, how well are we making medical decisions the next day in clinic? I don't know. So as interns, we learn the sick versus non-sick approach. So it's expected that you won't necessarily know what's wrong with your patient, but you can go see 30 sick kids in the ER and figure out which kid needs treatment first. And that's your job as an intern. And that's a skill that we need to remember when we're evaluating kids for rare disease as a primary care doctor. We might not know what is wrong with this patient, but we should be able to say, hey, they're not responding to our usual treatment attempts. Our usual tests are failing. Where do we need to seek help? With which kid? Because we can't give every kid a rare disease workup. That's not appropriate. So we need to be able to figure out which kid is that kid that needs help from us. So how do we think? So we use different types of reasoning styles depending on the type of case we're seeing. Our differential diagnosis, in other words, like our list of things that could be causing the symptoms, are based on a symptom. So are we making the differential based on the right symptom? And we have to get lucky and hope the patients told us the right symptom. We're trained for pattern recognition. That's how we study for boards. But it's not really that great for diagnosing rare diseases or uncommon presentations of common diseases. And a big thing is, I know a lot of doctors, we seem arrogant and cocky. But actually, our biggest problem is sometimes our lack of our own confidence. We all are feeling like we're faking it till we're making it, and that our colleagues are much smarter than us, and they know what's best. So unfortunately, we rely a little too much on our previous diagnosis a patient has been given, and we sometimes, if it says it on the problem list, we accept it at face value instead of really reconsidering, was this the right diagnosis? So we really need to learn to separate parsing out what's a fact versus what's been told or what's been written down or diagnosed. So reasoning styles, and these are, this is fun to think about. This came from Kligman et al., a cool paper called How Doctors Think. And it talks about abductive versus inductive versus deductive reasoning. So abductive is you've got a few features that kind of come together and it helps you say, oh, I think this disorder, here's the test I can order to see if I'm right. So for some, typical facial features, a certain type of heart defect, you'd say, I think this might be trisomy 21 or Down syndrome. I better order your karyotype. And that's when kind of our medical training works really well. Inductive reasoning is for more vague symptoms. So a baby's not gaining weight well, or what we used to call failure to thrive, and how to work that up. And we throw a whole bunch of tests at that. It doesn't always yield us a successful diagnosis. And deductive is when there's not like an actual test you can order, and there's kind of categories of diseases. And we have these diagnostic criteria where if you meet 3 out of 5 major criteria and 2 out of 5 minor criteria, or 4 major and 1 minor, so things like rheumatic fever, Kawasaki disease fall in these categories. And these are always a little bit harder to diagnose and really require a good amount of time and skill. And how we think is influenced by our patients. So if the patient's biggest concern is rash, we try and be good customer service providers, and we will focus on the rash. But a rash can be pretty nonspecific, and we might ignore the other 10 important symptoms in the room. So biases. So there's different types of bias that impact how we think and impact the ways we're wrong. So things like recency bias. So I saw 3 kids with X particular uncommon diagnosis in the last week. It's going to be at the forefront of my mind when I see the 4th kid. And unfortunately, I might try and lump that kid into that category. My brain tries to make things easy for me. Anchoring bias. So sticking to the first diagnosis landed on. So if there's one symptom that we're told about, like joint pain, we're going to start thinking about arthritis, but we might ignore the other things that might be causing it instead of just, really taking a good picture look at this. Availability bias. So thinking about a patient who has similar features, either disease features or maybe at worst looked like them. And this is where we can really run into problems unless there's a specific facial feature we're thinking about. If it's just, oh, they look a certain way, they keep their hair a certain way, they dress a certain way, that's not an appropriate way to provide a diagnosis. But that does interfere with how we think. Framing bias. So this is false assumptions based on travel. So, 22 months ago, I had a family that had to actually move back. They'd been doing some work at a university in China, and they had to come back to the US as COVID was coming out. And of course, the family had traveled, so everybody's assuming that this poor family had COVID, when in fact the kid just had a regular cold. Or back when there was, the bigger concern for Ebola here in the US, and we'd be asking ancillary travel questions. It's appropriate to include these things in terms of thinking about what might be wrong, but sometimes we over-rely on them and we jump to faulty conclusion, and that's what framing bias is about. Premature closure. So our brains are trained to solve puzzles immediately. So it's like 20 questions. You feel better if you get it right on the second question instead of the 20th question, but the important thing is to get it right. So failing to seek additional info because we close our brains off when we think we have the answer. And then attribution errors. So this is where, for whatever reason, we like to use words like mildly, like, the child is mildly short of breath, or mild weakness of their lower extremities. And I'm not sure if we do this to comfort ourselves, to comfort the families, because we're not confident in what we're seeing. Or since patients can read our EMRs now because of CARES Act, are we going to try and use these words to provide a softer blow to families? I don't know. But it can actually kind of mislead us and make us not take symptoms or physical exam findings seriously enough. So sometimes a case can have multiple biases. So I keep coming back to inflammatory bowel disease, but I was seeing a 10-year-old a few years ago for recurrent joint pains and swelling or arthritis. And she had abnormal inflammatory labs. She got referred to a great rheumatologist, had been seen in the ER multiple times, and nobody could figure out what was going on. They were diagnosed with a post-infectious reactive arthritis. This is really common after some viruses like CMV and EBV, the virus that causes mono. And it seemed pretty reasonable. And they were getting referred to me because this kept happening. And I was kind of stuck. I didn't really know what I was going to do with this kid. I was asking the same questions, getting the same answers, obviously. So I finally asked her what bothered her the most, because I really ran out of things to ask. And she said, the blood in my stool. I said, what? How have we not found out about this already? And that suddenly changed how I thought about this case. And she had extraintestinal manifestations of Crohn's disease, when we all should have been thinking about Crohn's disease at the start, because that can be caused by, that can have arthritis as a presentation. And we all should have known better. But what happened was we all had anchoring bias and premature closure. So how do we get around this? So we need to be aware that these biases exist. Our brains are not perfect. Our brains have not evolved to do diagnostic medicine. That's not as humans where we're at. So we need to be aware. I think sometimes it's helpful to pretend we have a medical student with us. And if we said to our medical student, what else could this be, to try and teach them, that can help ourselves think through what might be wrong. Hit shuffle on the problem list. So for any of you guys who might have ever listened to like a Discman with a CD, I still have a CD player in my car that I use. Hitting shuffle, not listening to the CD in the same order, right? So so that can actually help. So if the diagnosis is based on arthritis, that's the buzzword we go off of, we might be wrong. But if we say bloody stools first and then arthritis, we might get it right. And then make a list, like what is known, what is thought, and what is unknown. And then you can ask the right questions, order the right tests to help you get towards the right diagnosis. And we're seeing our patients as snapshots in time. We're not really seeing the full video. So what are some disease level factors that mess us up when we're trying to diagnose rare diseases? Is the disease behaving the way it normally does? So diseases don't read textbooks, so they don't necessarily present the way we might remember having learned them. How variable is the phenotype? So for a given rare disease, there can be different severity of symptoms. There can be some symptoms that are always present and some that only are there sometimes. And we can falsely throw a diagnosis out based on this. Is it a disease that lends itself to a simple diagnostic test, or is it one that falls more under like a criteria where they have like 5 major and 2 minor, something like that? And has the disease been modified by previous treatment attempts? So if a kid's been having a lot of chronic cough, for instance, and they've had wheezing, has somebody treated it with steroids, even though they're even though there wasn't a history of asthma? And are we somehow messing up our future diagnostic of lymphoma or leukemia? So really understanding what's been done before. And does the disease presentation become more complete over time? So diseases like neurofibromatosis, a child might not have all the features early on, they might come later. So just keeping an open mind to what might be causing seizures or some other presentation, knowing that you might not be seeing all the symptoms right away. So thus somebody might not meet diagnostic criteria at a year, but they might at 5 years. So patient and parent level factors. So as a family, when are the families seeking care? At what part of the disease process? Are they coming the first week? If you've had 1 week of symptoms, we're less likely to think that this is a chronic rare disease. If it's been there a while, we should really start thinking about it. I really ask my families to come back and see me often, because these symptoms all warrant their own visits. I want to do a good job with them, but I can't tackle this and COVID symptoms and ADHD all at once. Well, sometimes there might be an overlap. Sometimes it's really not, and I can't do everything in 20 minutes. But I'm always willing as a physician to get the right answer eventually. So what that means is, please, let's tackle as many things as we can today, but please come back in a month so we can talk about the rest of this. How do you communicate with us? Both in terms of how you describe things. I'll be honest, if families have a harder time describing things in an organized way, it's really hard for me to understand what's going on. That's my own problem. And I hate to put the responsibility on families, but it falls that way. The more a family can think about how to organize their thoughts before we see each other, the better the visit's going to go. And again, we really rely on families. And again, that falls with us. You shouldn't have to rely on yourselves to say it right. But the fact of the matter is we do a better job when we hear it the right way. So like we talked about, how often do you come? What resources does a family have? Can a family come back as often as I'm asking? Has the family read about this a lot? Do they have some good ideas for me on what to order? And race. So I'm listing it here, but this really falls under provider systems, etc. There's a lot of differences between all of us, and this impacts how we get care. So, and I'll talk about that more in a little bit. So again, we're really dependent on you all steering the ship here, which is unlike like if you have an acute injury, which you might sustain from that kid driving. You know, when you come in, with knee pain after you've had somebody slide tackle, yeah, we know what to order and we know how to work you up for an ACL tear. But when it's got some of these more rare indolent symptoms, it's gonna sometimes be very driven by the family, and we need to take some of that burden off of you. So how does race impact diagnostics? So one area is inequities of referrals. So the UDN, or Undiagnosed Disease Network, shows that there's no difference in rate of acceptance of their referrals. So when somebody gets referred to them, they don't have an increase in acceptance of who they refer based on race. Their percentages are the same. But the referred patients themselves are overwhelmingly white, non-Hispanic patients. So why is that? Is it that those families are getting listened to better? Is it that those families might have a different set of resources? Or is it something that's even a little bit different, that that the diagnosis itself might be race dependent? So a lot of disorders that are in textbooks have been, the description of them have come from white patients. So we don't have enough patients of color that are sometimes representative that have been utilized before to describe features. So a certain disorder might look a little bit different in a child of a different race, and we are ignoring some of those patients with our imperfect textbooks. Sometimes this might keep us from putting the dots together for a kid with a rare disease that has multiple layers of symptoms, that we're just not thinking about them because they don't look a certain way. So our medical texts or dysmorphology atlases have to incorporate more diverse populations. And this there's a really nice paper that came out last year from Freiman and Wojcik, if any of you are all interested in seeing it. And I've got the references at the end of this talk. I really like this slide that they put together from their paper, though, and this really walks through the diagnostic pathway of, first for any kid when disorder might be suspected that's a genetic disorder, how the referral works, who evaluates them. But it has on here kind of what the barriers might be that are a little bit race-based, or where the race might get in the way. So we might be less likely to suspect it in a racial or ethnic minority based on facial features. We might be less likely to refer. There may be some barriers. So for instance, if a family is not, who doesn't have English as their first language, they might have a harder time accessing the referral itself. Transportation can be different for people across different populations. How has a family been impacted by the healthcare system before? Has the family been mistreated based on race before? How likely are they to trust their doctor? How likely are they to trust genetic testing? All these kinds of things are real and impact families and really impact how well we diagnose rare disorders in people of color. And this is just another reminder of really how multifactorial all of this is. So systems level factors. So how accessible is one's healthcare system? Can you get in to see me? Right now, my next available checkup is 2.5 months from now, not because I'm a great doctor, but just because we don't have enough access. Transportation, can you get in to see me? How far is your home from where I practice? What's the weather? Can we start using telehealth better for this? What are our policies for telehealth? So for some strange reason, a family I take care of for depression, an 18-year-old who I treat for depression, I can see them for telehealth as long as they're going to college in North Carolina. But if they cross to go to Virginia, I can no longer provide telehealth to them legally. And does that make any sense? Are there ways that we should be thinking out around this? Is there a good way for communication between the PCP, the subspecialist, families, the diagnostician? Are they all in the same healthcare system? Who's going to take ownership over making this diagnosis? How do families get the same healthcare within one system where we can all communicate with our subspecialists better, or is it different between like Duke and UNC? I have a lot of families that split for both, which is fine, but it does make communication a little bit harder. Or if depending on what your health system is, how well do our EMRs talk to each other? That's something that really should get better over time, and I'm kind of dismayed that it hasn't. How good of an access do I have to great subspecialists? I have amazing subspecialists that I can ask questions to. I have a great network of people. I know who to ask. I know the best way to get in touch with them. Some of them do better on email. Some of them do better through our health portal. But I at least have that access. And a lot of pediatricians just don't have that good door in. So how can we help them do a better job getting access? And that's where a diagnostic clinic can be really, really helpful. How fragmented is the care that patients are receiving? How much collation has to occur? How much is on patients and families to put all this health stuff together into a binder? I'm not sure if any of you have binders of healthcare because you've had to work so hard to keep your stuff organized. What if you move across the country? Are your new providers going to be able to access your old records? Other systems level things. How affordable are the tests and evaluations? One stressful thing is a lot of times things can be covered, but it's hard to answer that for sure before the test gets done. And that's a burden that shouldn't be on families. We should be able to do a better job getting that question answered before we order a test. How long does it take for prior authorizations to go through? Does your physician have time to do prior authorizations? These sometimes take us 45 minutes. So if we're doing a busy clinic, when are we supposed to talk to the insurance company to get this approved? And then the COVID pandemic, and how has this impacted our healthcare system? Well, it's made it hard for a while to get into clinic. Early in the pandemic, we often weren't seeing patients that had fevers, so you might screen out if somebody in your home has had a fever recently. In the summer in North Carolina, if you didn't drive with the air conditioning on, your temperature is going to be elevated upon arrival to clinic, and you might not get seen that day. If you have a recurring fever, so something like FAPA, or other periodic fever syndromes, yes, you have fever. Does that mean you can't get seen? And then physician call-outs. This has actually gotten a lot worse in the last month. A lot of us have been having to call out sick because we've been symptomatic and haven't been able to get timely testing just because of the shortage of tests. And this can be really problematic if y'all have been waiting to get seen for months. When's our next open slot? Has this delayed your time towards when you could get diagnosed properly and start treatment? That's not fair to patients, right? This has delayed other research. So for a long time, clinical research wasn't able to occur outside of COVID related. We weren't allowed to have research personnel in clinic earlier in the pandemic. Funding has been prioritized, rightly so, for COVID related diseases, but this has impacted when other research has gotten approved and funded. And then just no real knowledge of how COVID impacts patients with rare disorders. Just as I don't necessarily know how some of my patients with common disorders are going to do, I really don't know how my patients with rare disorders are going to do when they get COVID, or if they get COVID, or will the vaccine protect them as well as it does others? But I think we can spin that around. I think we can really learn a lot from COVID. We at my practice have been clamoring for years to be allowed to do telehealth and kept being told, no, you cannot. And then COVID hit, and within a day, we were allowed to do telehealth. Now, while it took a while to have it work well, this really taught me a lot that yes, we can think outside the box when we need to as a health system. Our geneticists are doing a lot of telehealth visits. While sometimes you need to kind of in-person visit to really see things well, there's a lot you can accomplish by telehealth. For my autistic patients, they've been able to get prompt evaluations with something called the tele-ASD, which was getting developed by Vanderbilt shortly before the pandemic started. It's actually worked out beautifully. It's really helped a lot of my patients get access to diagnosis without having to expose themselves or their providers to risk, or it's just frankly helped with people with difficult times with transportation. And I found this allows for more frequent touch points with me for my patients. So even if we haven't quite figured it out, I can set up a telehealth visit in a month. It's less burdensome on families to have to maybe not come in quite so often in terms of transportation or missing as much school. And it's allowed us to do a better job of saying, hey, we haven't quite gotten this right yet. What else do I need to be ordering? What else do I need to be thinking about? So remember, we've got these barriers, and a lot of these don't really have good workarounds, but some do. So let's think about what's controllable here. The disease-dependent factors, not controllable. We just need to, understand the characteristics we leverage. So knowing, hey, I shouldn't rule out this disorder because y'all might not have had time to develop all your symptoms yet. Patient level factors, generally not controllable, but it's helpful for y'all to understand what we need from you to do a good job to diagnose you. And really the factors that should be able to change the most are the physician and system level factors. So like I talked about, can we really know a ton about every single disorder? Kind of, it's temporary. So we get a lot of continuing medical education, and for the month afterwards, I'll say I might be pretty sharp on that topic, but over time that kind of fades. But can we really impact how well we're educated about rare disorders in general? When to suspect one, when to have a good algorithm for how to test, how to access genetic testing, things like that. Communication skills. A lot of us, myself included, could do better with our communication skills. Time. This is systems level. How can our system help us do a better job having time? So quality care instead of quantity care. And I think we're actually moving in that direction. Cognitive patterns and bias. So we can't eliminate bias, but we can be aware and know the tricks that our brain is trying to play on us, and that can help us be more thoughtful in our evaluations. Racial and social biases. So what can we do systemically? How can we include more patients in databases? How can we improve access to care? How can we build trust in the healthcare system for people who've been mistreated in the past? And this is something that hopefully our newer generation of pediatricians can do even better at than my generation can. And stress. So we're under a lot of stress as physicians. Y'all might not want to hear this, but we are. And our jobs sending us burnout surveys and telling us to do yoga in the middle of the day isn't particularly productive when that's when I'm trying to call patients back about lab results. So what can be done to help make us work efficiently so we have the time to de-stress instead of filling out another burnout survey? We as physicians can do a better job listening, and we can train ourselves to ask when something seems outside of normal. We can openly ask families, what do you think might be going on? What are you most concerned about? We can do this at the start of a visit. As patients and parents, we can continue to speak up on our child's behalf, and we can really agree that interval follow-up might be necessary. As healthcare system, we can improve access for all families, even if they're not in the geographic proximity, to good geneticists and diagnosticians. Families that live around here are lucky. We've got great healthcare in a pretty relatively small population. We've got Duke, UNC, ECU, Charlotte, Carolinas Medical Center, Baptist at Winston-Salem. We've got great healthcare systems here, but not every place has so many great healthcare systems for so few people. We need more time and less stress. We can do better research on health disparities and racial inequities and how this impacts genetics and genetic disorders. We can have more inclusive databases. And as physician educators, we can shift medical education to include better practical application of genetic testing. Now that we can maybe worry about less acute life-threatening diseases, we can do better jobs with more rare disorders. And when able, we can expand the role of newborn screening. So hopefully, I can't see any of you. I hope some of you are still awake. I hope you didn't ruin your computer monitors by throwing tomatoes at the issues with my talk. But I really appreciate you guys having me, and thanks for bearing with me, and I appreciate any questions you all might have. And if you're interested, here are some of my references.
Thank you so much. I think we had trouble seeing your presentation, but can you are you allowed to send that to me?
I will absolutely email that to you.
All right, and I will post it for everyone to have access to, Dr. Eichner. We did have a question about the whole genome sequencing. And the question is could whole genome sequencing become the standard of care, or if whole genome sequencing was the standard of care, would the diagnostic journey be considerably shorter? And we get into a whole host of privacy and my rights and as a patient, that discussion, but that is a good question.
Yeah, I think that's a really interesting question, and I think the question I think there's obviously ethical issues, Jeff, like you're talking about, right? So, you know, do you want to know all these things? How's this going to impact insurance? If insurance knows what risks you may have, if they might be true and unrelated, and if you find out information that's not a question you're looking for, you know, how does that impact you as a patient? How does that impact your own stress and mental health? If we had better ways to know what the results of this genome sequencing meant, I think that would shorten the diagnostic journey. My assumption is 20 or 30 years from now, we're going to be in a very different spot. I think we're going to be having a better understanding of how to order specific tests instead of things like whole genome. And I think if we can get there, that'll be the sweet spot between overdiagnosing something that might or might not occur, and, you know, ruining people's insurance possibilities for the future, causing them persistent anxiety every time they might feel more tired one day. But I think you're right, though. If that was more standard, we could probably shorten people's diagnostic journeys.
Okay. And I think you're right. That kind of leads into my next question about along that line. You said in 20 to 30 years, you think we'll be in a very different place. But instead of the genetic sequencing as a whole, the whole body genetic sequencing, you might be able to do more of a rapid, targeted genome sequencing based upon, would you say that would be based upon your diagnostic analysis that you have? Patient comes in, they exhibit these behaviors, and being able to turn and say, okay, we should probably run this genome sequencing test. Is that what you're thinking?
I think that would be ideal. I think we're a ways from it. Just because genes don't always predict phenotype, since we are such a diverse population, I think it's going to be hard to suddenly move to that, because a gene might mean something different in a different person. And we also have to be careful because probably there's multiple genes that would cause the same exact condition.
Right.
There's probably more variability within phenotypes or disease processes than we're aware of. But I think it would be for a chunk of patients the right answer.
Yeah, and I think too, and I hope we work with another organization that's a rare disease organization called Rare New England, and they have a big push for genetic. They actually have job fairs for recruiting medical students to go into genetics, because it looks like the genetics field there's not a lot of doctors in that field by comparison to other specialties and things. And I know even at Duke, I think you have a very small group of geneticists that are on staff there. But the one thing that was interesting that we discovered too is, even if you run the genetic panel, you may end up with more questions than you had before.
Yes, exactly.
So, yeah.
If anybody in this room is in my same era, there's a band called Everclear that I listened to in the 90s. And a lyric that they have, I think, is really helpful. It's, don't ask for questions that you do not want to hear. Because sometimes we ask a question and we get an answer that we're not prepared for, that we don't have an intervention for.
Right. Yeah, exactly. So, you know, you kind of touched on that in the beginning. The next question, kind of shifting of gears though, but if you wouldn't mind reiterating for me, you know, telling the difference between a diagnostic pediatrician versus a general pediatrician. And I know you said that most of the time you do general pediatrics. I mean, you're doing the general checkups, you're giving vaccinations, you're treating, you know, whatever comes through the door. But what is that difference between the diagnostic person versus the standard pediatrician?
That's a great question, because the answer is probably really variable based on where you are.
Okay.
So in some centers, it's going to be a geneticist. or somebody who only sees, rare diseases. In other settings, it's going to be, honestly, a rheumatologist or an infectious disease specialist. They are two subspecialties that are great at not only saying, hey, this isn't rheum or this isn't infectious, but at really thinking through a very thorough evaluation for what might be going on with somebody. And it really depends. So the background for me was a little over 10 years ago. Our former department chair, who had trained elsewhere and had worked elsewhere for a while, realized that we didn't have what's called a diagnostic clinic. So patients would get referred to either endocrine or GI, and they, get ruled out from a lot of things, but not get ruled into something necessarily. And it became a really rough journey. And he thought that we should actually start a diagnostic clinic, meaning, somebody who could kind of come in, look at the big picture, take a step back, review records, ask the questions again and again and again in a different way, do an exam, figure out what testing might be helpful, or if nothing else, be a good portal. So let's say genetics has a year-long wait. If I know what test to order, can I get somebody into genetics sooner once I get that result? And so I think broadly, as a diagnostic pediatrician, as a general pediatrician who is able to look at the whole patient and evaluate the whole patient and not just rule out a certain subspecialty type of diseases, and hopefully they're linked to resources and can ask the right people the right questions.
Fantastic. Yeah, I know that for, and selfishly, but I can talk about our own story with Cambria. You were someone that we sought after when we moved, because we actually moved from Kansas to North Carolina in the middle of the pandemic, just simply because we had great doctors out there, but we were going to like 5 different hospitals to do things, or 5 different clinics and stuff. And when we came out here, Eden had been online, she'd done the research, she'd looked you up, and she jokingly says a lot of times, she goes, I was your fangirl. So that, and we need to see Dr. Eichner, but here is why. He's a diagnostic pediatrician, and with Cambria's condition, he would be the best fit for what's going on with her. And I will say, as a parent, it is again, kind of, it is comforting to walk into your office knowing that you are a diagnostic pediatrician, and that you have that role, that you're looking at these things from maybe a larger view of those possibilities. And I do think that it helps shorten the time to diagnosis in some cases, because I mean, here, truthfully, with Cam, we had been here for 3 months and we had a new diagnosis on something that had baffled people back out in the Midwest. What would you recommend and say to someone if a diagnostic pediatrician is not available in your area? Maybe you're in rural America. I mean, and that's, where I grew up, we were happy to see a doctor. We didn't call them pediatricians or anything. We just had a doctor. What would you say to them in helping them to determine what is their best course of action?
That is a great question, because and I didn't do a good job addressing this in my talk. So I talked about race and how that impacts access to genetic and diagnostic medicine, but other barriers do too. So geography is a big one. I am hopeful that telehealth may help with this.
Excellent.
Because if there's a way for more geneticists to do more by telehealth, I think some of the answer may be there. There are some, I don't have a ton of knowledge on this, there are some healthcare companies that are looking to kind of market who can be special opinion doctors, like second opinion doctors, and having a way to leverage those people who may have areas of expertise and kind of match between a patient who has symptoms, and they could either self-seek this out or their physician could refer them to somebody who is then going to be able to do like a second opinion e-review type case and or a telehealth visit. And that is something that I think is kind of the next step. So either a pediatrician who's unequipped to handle this might have connections elsewhere. of say, hey, I honestly don't have anybody here who can help you, but I trained with somebody who's now, at Stanford. We all keep in touch with our old colleagues, and sometimes you have a connection there. Or like I talked about, some of these more third-party industrial type groups, I think, are going to be a big answer. Obviously, that raises some separate equity concerns, because I think for some of that, it's going to be a cost-specific problem. But my hope is, as that becomes a little bit more of a mainstream idea, there'd be more access to that for everybody, instead of just people who can afford it. Or
right, based upon your insurance plan, that type of thing. What are you going to be able to do with it? And I do think, and we have used telehealth apps in making some telehealth calls, largely because of COVID, and some of it was availability. Too. It's the middle of the night, where you can do that instead of an ER call type of a thing. We are coming down to just the last few minutes of this hour, and I think thank you again. This has been absolutely magnificent, Dr. Eichner. I appreciate you taking the time and helping to spread awareness with it. Let's see, we did have one last questions with this, but no, with it. Okay, no, we're good here. But I wanted to just thank you.
I'll say out loud what I just put in the chat in case you all can't see it. So my own technology issues and performance anxiety led me to forget to hit screen share, even though it's 2022.
That's okay. It's it was still a great presentation, sir, with us. So wanted to thank you for that time. I know you're busy. I know you got a tremendous caseload right now with it. So I know this time is precious, and we really appreciate you coming on, sharing.
I was really grateful to come talk. I appreciate the invitation. That means a lot that you thought to invite me. So
well, thank you.
Thanks to you and Eden.
All right. Take care.
All right.